Now, how to monitor your IUI cycle. So, when we are talking of follicular monitoring, you have to monitor not only the number and size of follicles, but the number and thickness of the endometrium as well. So I have told you when you should start doing the follicular tracking, when you are doing oral ovulation cycle, and when you should start doing when you are doing the gonadotrophin standalone cycle or ovulations plus gonadotrophin standalone cycle. So what you are monitoring? You are of course monitoring the number of follicles in each ovary, the size of follicles, you are paying attention to the dominant follicle, you are paying attention to the endometrial lining. When it's time for ovulation, so you are seeing whether the patient has ovulated or not. And at the same time, you are paying attention to the overall ovary and uterus for any pathology. How often you should do? Of course, you should start with the day 2, day 3, that is your baseline scan, to rule out any pelvic pathology in the uterus or ovaries, and as I said, to do the antral follicular count. Because when it comes to the reliability, whether to rely more on AMH or on AFC, which one you will rely on? More on AFC, because it is done by you. AMH has got its own limitations. It is done in the lab. So when it comes, sometimes we do get discordant results between AMH and AFC. So go with your AFC rather than AMH. How often you should be calling them for follicular tracking? Early follicular phase, we don't call them before day 7 or day 9. Around selection of dominant follicle, if she is on gonadotrophin therapy, do call them every alternate day. And if she is approaching ovulation, you can call them daily, but don't call them too frequently. At critical decisions, points closer to ovulation, daily ultrasounds are often needed. The frequency should balance the monitoring needs. At the same time, you have to reduce the patient visits and of course the cost. So you have to individualize how many times you want to call her for ovulation monitoring. A follicle that is of more than 10 millimeter in diameter, you can calculate, usually grows at a rate of 2 to 3 millimeter. Let's stick to 2 millimeter per day. So if there is a growth of 2 millimeter per day, you count and call her on when you are expecting the size of 16 millimeter. This will has no internal echogenicity. It will have very thin walls, and you have to monitor the lead follicle. A mature follicle should be round, thin-walled with no internal echoes. The shape of the follicle changes from round to polygonal when there are multiple follicles due to the pressure effect from the adjacent follicles. In such follicles, the follicular volume you have to consider instead of a diameter, which is calculated as diameter 1 into diameter 2 multiplied by diameter 3 into 0.52, where D1, D2 and D3 are 3 diameters of the follicle in the perpendicular ones. So this is how you will be calculating the follicular volume. The follicle shape may become ellipsoid if too much pressure is applied on your transvaginal probe. So how much pressure you are applying by your TVS probe, that also changes the shape of the follicle. And therefore, scan should be done with only optimum pressure applied by your TVS probe. A mature follicle, as I said, in gonadotrophin cycle is 16 to 18, and in oral ovulations, it's 18 to 20 millimeter. It has thin walls, regular round shape, and no echogenicity in the lumen, and it shows a thin hypoechoic rim surrounding the follicle and sometimes cumulus-like shadow you can see. This thin hypoechoic rim and cumulus-like shadow develops approximately 36 hours before the rupture. That is how we monitor and time our IUI. A flimsy irregular line is seen inside the follicle parallel to the wall about 6 to 8 hours before rupture. But we don't call our patient that frequently for monitoring. Whenever you are counseling your patients, do tell them what you are seeing is follicles and not the oocytes. Because roughly अपन बोलते अंडे, एक अंडा दिख रहा है, दो अंडा दिख रहा है, तीन अंडा दिख रहा है, and they say कि कहाँ गए हमारे अंडे? So now I give them an example of the grape. जैसा अंगूर होता है, हमको सिर्फ वो दिखता है सोनोग्राफी पे, उसके अंदर बीज है कि नहीं, यानी egg है कि नहीं, we can't see with the naked eye. Please tell them very clearly in IUI on sonography, you are not seeing the eggs. You are seeing the follicle like a grape. You really don't know whether this follicle has egg inside. At the time of ovulation, whether this egg really reaches up to the uterus, because you can't see the fallopian tubes on the ultrasound. You can't see the passing of the eggs from the fallopian tube. So I tell them there are many factors which are not in the control of the doctor in IUI cycle. Whereas in IVF cycle, up to the embryo formation, we supervise. We know the quality of the eggs, how many eggs you have got, whether there is fertilization, how many embryos have formed. But in IUI, everything is on assumption. What you are monitoring is only the size of the follicle and the thickness of the endometrium. Rest all is assumption. That is why the success rate of IUI is less as compared to IVF. So what are the signs of ovulation on ultrasound? The follicle suddenly collapses, margins becomes irregular, and you will see the fluid in pouch of Douglas. Now we have also started adding Doppler in follicular study. The Doppler parameters are mature follicle will show vascularity in at least 3/4 of the follicular circumference. PSV is 10 centimeter per second, and at this time LH surge will start, and this is the right time to give SCG trigger if you are doing by LH kit. This was a very interesting paper published very recently in 2024, and the title of the paper was a prospective study on the color Doppler indices of follicular and endometrial blood flow as a predictor of pregnancy in IUI cycles. We have many papers for IVF, but this was for IUI cycles, and here they divided and they gave grading to the follicular vascularity. Grade 0, follicles do not have any blood flow. Grade 1, up to 25% of follicular circumference. Grade 2, 25 to 50% follicular circumference. Grade 3, 50 to 75% of follicular circumference. And grade 4, follicles have blood flow visible in almost 75 to 100% of the follicular circumference. So on the basis of this vascularity of follicle blood flow, they say that grade 1 and grade 2, they will give you less pregnancy. Grade 3 and grade 4 follicles are definitely good quality, high grade follicles, so they will give you a good clinical pregnancy rate. This was all about the follicle monitoring. Endometrium has its equal share when it comes to your success rate. So morphologically, you can see that there are 3 types of endometrium which you get. Of course, what we want is the receptive endometrium. So the morphologically, the endometrium is graded as the best grade A when it is triple line endometrium, with the intervening area as hypoechoic as the anterior myometrium. See, this is the grade A. The echogenicity is attributed to the development of multiple vessels penetrating in the endometrium. I will be coming to the Doppler in the endometrium as well in my next slide, producing multiple tissue interfaces and therefore causing the echogenicity and due to glycogen storage in the endometrial columnar epithelium. The endometrium is graded as intermediate or grade B when it is multilayered or triple line with hypoechoic internal areas, and in grade C, which is the most unfavorable endometrium, it is a homogeneous isoechoic endometrium. Now coming to the Doppler flow evaluation of the endometrium. As for follicle, for endometrium also, the physiological maturity is essential, which again can be assessed by color Doppler. Segmental uterine artery perfusion demonstrates significant correlation with hormonal and histological markers of uterine receptivity, reaching the highest sensitivity for subendometrial blood flow. So on color Doppler, the endometrium which is mature shows vascularity in zone 3 and 4, or you can say in the subendometrium and endometrial layers. This was a paper and this was the author, that is Applebaum. He again gave the categories to the endometrium, that is zone 1, zone 2, zone 3 and zone 4. In zone 1, the vascularity on power Doppler is seen only at the endometrio-myometrial junction. Zone 2, where vessels penetrate through the hyperechogenic endometrial edge. Zone 3, when it reaches intervening hypoechoic zone. And zone 4, when they reach the endometrial cavity. So you all can guess that zone 3 and zone 4 are good endometrium for giving you the good clinical success rate. Now we don't pay attention to only the endometrium or the Doppler flow, because age-old teaching is endometrial thickness. So the success rate of your IUI depends when you are having the optimum endometrial thickness, that is 9 to 10 millimeter. If your endometrial thickness is less than 6 millimeter, your chances of getting pregnancy is minimized. If it is more than 14 millimeter, that also we don't want. So we want the optimum thickness of the endometrium. So on follicle monitoring, this is the slide where I have put all the points. Follicle 16 to 18 millimeter, endometrium 8 to 10 millimeter. When you are seeing for the morphology, follicle should be thin wall, no internal echos, it should be hollow. On endometrium, it should be grade A or grade B, not grade C. Vascularity, 3/4 circumference of the follicle, and if you are seeing for the vascularity, it should be in the zone 3 to 4 when you are looking at the endometrium. If you are measuring the RI, it should be 0.4 to 0.048 in the follicle and less than 0.5 in the endometrium. So this is all the parameters which you will be looking when you are monitoring the cycle. So the follicle tracking, of course, here we are doing by ultrasound. It will tell you about the follicles and the endometrium. It also tells you about the dominant follicle and when you should give trigal. Start from day 2, day 3 and decide on the frequency depending on the individual case scenario.